The following lecture is aimed for dental students, interns, junior trainees, junior residents of oral surgery and oral maxillofacial surgery, as well as junior residents of other dental specialties. I also dedicate this lecture to my fellow colleagues and dental practitioners of several dental specialties all over the world. May you all benefit from it. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed Al-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital Cairo in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. The main topic for today, I find it one of the most important topics in the dental practice, is the management of the medically compromised patients. And our topic for this lecture is the management of the pregnant patients in the dental practice. And although pregnancy is not considered a pathological entity, yet some potential problems arise from physiological and psychological changes that occur during pregnancy, and such problems need precautions and should be kept in consideration. Of course, first priority to come in mind is to avoid genetic damage to the fetus. Our main concern, or our priority main concern, is to protect the fetus against any genetic damage. In the dental practice, we have two main issues that can cause such damage: dental radiographic imaging and drug administration. And of course, we all know obviously that performing dental surgery will always involve one of them or both of them. So when planning dental surgery, we have to be careful to avoid genetic damage to the fetus. However, when we review the management guidelines, we have to bear in mind few issues: when to treat and when not to treat, precautions taken preoperatively, and precautions with using of the drugs, and precautions on the dental chair during treatment. And there would always be a dilemma when you face decision making and when you categorize your procedures into elective and emergency. First of all, any elective dental procedure should be deferred until after giving birth. However, if you face emergency situations such as pain due to acute pulpitis, acute periapical peritonitis, acute periapical abscess, pericoronitis, you should deal with it promptly. Because if you don't deal with it, the patient will resort to analgesics, antibiotics, and if such drugs are not safe for the fetus, they might cause genetic damage. So remember always that dealing with emergency situations will decrease the damage on the fetus and the mother herself. When you face a dental emergency or an emergency situation and you need to do dental radiography, please use the lead apron to protect the fetus and the patient, and use the thyroid collar also during the radiography, and please use the digital radiography with the sensor to minimize the time of exposure and to minimize the radiation dose as much as possible. And only we should limit the imaging to the area of interest and the chief complaint only. And once the decision is reached and we know what procedure are we going to do, we should consult the obstetrician and tell him what procedure are we going to do and the type of local anesthesia and the vasoconstrictor. And lab investigations should be done to rule out gestational diabetes and to have a good check for the mother's health. And then we should ask ourselves, what is the best trimester for us to go interfere with the problem? The best trimester to do whether elective or emergency treatment is the second trimester, followed by the third. And as much as possible, we should try to avoid the first trimester. And coming to the management protocol of the dental chair, we should implement the stress reduction protocol thoroughly. Local anesthesia also should be limited as much as possible, and the best is lidocaine with adrenaline. Long procedures should be avoided. The patient should be allowed to void in the restroom frequently, because late in pregnancy the fetus exerts pressure on the urinary bladder, and so the patient needs to empty it frequently, and it's better to let the patient go to the restroom before entering the dental office. And also we should avoid the lengthy procedures as well. Last but not the least, the proper chair position is mostly upright, or the torso should be turned to one side during the dental treatment, because keeping the patient in a supine position, the gravid uterus is going to exert pressure on the inferior vena cava, compromising the venous return to the heart, and hence compromising the cardiac output as well. So please put the patient more upright, or let's turn the torso to one side during the dental treatment. And now we come to the most important issue of pregnancy management, which is the drug prescription. The FDA had categorized the drugs according to the safety for the pregnant female into A, B, C, D, and X. Category A, we have drugs are safe and they show no risk. Well-controlled studies in pregnant women have failed to demonstrate any risk to the fetus. And category B, there is no evidence of risk as well. Either animal findings show risk, but human findings do not show. Category C, where risk cannot be ruled out, and the human studies are lacking, but animal studies, maybe we have some positive studies for fetal risk, or lacking as well. However, the operator here can weigh the potential benefits against the potential risks. Category D, we have positive evidence of risk. Category X, these drugs are totally contraindicated in pregnancy, where studies in animals and humans or investigational or post-marketing reports have shown fetal risk that clearly outweighs any possible benefit we can get to the patient. And let's have a little application of this categorization. We can see that acetyl salicylic acid, category C or D, it's not used in pregnancy, and acetaminophen or the paracetamol, it is yes for use in pregnancy, and we can apply this on other drugs like morphine, category B, it is yes, and antibiotics, amoxicillin, metronidazole, erythromycin, penicillin V, and cephalosporins, gentamicin, category B and C, cephalosporins, tetracyclines, and chlorohexidine. Most of them are yes, however, tetracyclines are no, because they are category D and they are proved to have detrimental effects on teeth and bone formation. Let's see the antifungals, mycostatin, clotrimazole. Yes, we can be used during pregnancy. And to wrap it up, here is a list of medications that we should avoid during pregnancy, on top of which comes the aspirin and non-steroidal anti-inflammatory drugs, carbamazepine, Tegretol, which is used in the trigeminal neuralgia, chloral hydrate, especially if chronically used, steroids, diphenhydramine, antihistaminic, Benadryl, chlordiazepoxide, Librax, which is an anti-anxiety drug, pentosacine hydrochloride, it's a narcotic painkiller. We have also diazepam and morphine, nitrous oxide, especially if oxygen is less than 50%. Using nitrous oxide, we should use oxygen at least 50% or more with nitrous oxide. Phenobarbital, tetracyclines, and promethazine hydrochloride. Regarding the breastfeeding mother, most drugs can pass through the milk to the fetus. So when we prescribe a drug in the postpartum stage to the breastfeeding mother, we should bear in mind if this drug would do harm to the fetus or not. There are a list of drugs here on the left hand side where no apparent clinical effects on the breastfeeding infants, like acetaminophen, the paracetamol, antihistamines, cefalexin, codeine, erythromycin and fluoride, lidocaine, mipridine, oxacillin, and pentosacin. On the other hand, the list on the right hand side, they bear potentially harmful clinical effects in breastfeeding infants like ampicillin, aspirin, atropine, barbiturates, chloral hydrate, corticosteroids, diazepam, metronidazole, penicillin, and of course tetracycline. And when we talk about pregnancy and bringing a new life to the world, we should always remember Eva Barrow's words: the love of a family is life's greatest blessing. Finally, I would like to thank you for your kind attention. Thank you so much.